This is Heart Rhythm TV. I'm Roderick Tung. It's not so often that you open up the New England Journal of Medicine and you see two lead blockbuster trials that are related to electrophysiology. And with us today on Heart Rhythm TV, we have both lead investigators of early AF and stop AF, Jason Andrade and Oussama Wazni, one from Vancouver General Hospital and the other from Cleveland Clinic. Welcome, Jason.
Hello, good to see you.
And welcome, Oussama.
Thank you, Rod. Thank you so much.
Thank you so much for joining Heart Rhythm TV. There's so much to talk about, and we'll take it one at a time. Oussama, I know this has been a long journey for you. And what's really cool is if you look at both papers, references 13 to 15 are exactly the same for both papers. And yours in 2005, JAMA, Wazni, and Natalia et al., you did this on a smaller scale with RF and showed something similar. Can you take us through the journey a little bit and how this whole idea was conceived?
Thank you, Rod. So early on in my training under Dr. Natali and then later on as my, alone in our practice, we noticed just by taking care of patients that, the sooner we intervene with an ablation, the better the outcomes. And actually this came along, especially in patients we've been putting on Ticusine. So we had a lot of patients we place on defetelide, and they do well on defetelide, and then they have their first recurrence 5 years later. But by the time we take them to the lab, we find that the atrium is enlarged, and there's a lot of fibrosis and scar. So that's when we started thinking, okay, let's look at this. And we looked at it in persistent patients, and we found that actually what is more important than the duration of how long they've been in AFib is the more important aspect is how long they've been from the diagnosis of atrial fibrillation. And that's a paper we published a few years ago in persistent patients. We found that the longer from the time of diagnosis to ablation, the higher the BNP, the higher the CRP, and definitely much worse outcomes. And the cutoff point for that was really 1 year. So that's where this thought process started happening. And when I first designed the study, it was by a different name at that time, was, we want to do early ablation in those patients and drug naive. Now, the difference between RAFT1 and this is that here we really wanted to take those patients who are early in their disease process. Now, if you review RAFT, also they were early, but that was a smaller scale study. So we started, thinking about this protocol. And frankly, I want to give credit to Medtronic because they agreed to fund the study. And on a trip actually to Montreal to see how they make cryo, the cryo balloons and their catheters. And there, we were, they were thinking, I was like, what are you interested in? And I said, this is something that I'm really passionate about. And then, they looked at the protocol. It took a few years for them to get around to decide that they want to, participate. And that's how Stop AFib First was born.
Before we get into the results, I want to move over to Jason. Jason, you're coming off of the heels of a blockbuster Circadose trial. And the one thing that you've injected into all these RCTs that I've noticed is the use of implantable loop recorders. Tell us a little bit about the evolution of early AF for you.
Yeah, so early AF and Circadose both were conceptualized around the same time. So, being in Montreal, at the Montreal Heart Institute, we had a close collaboration with Medtronic CryoCath, sort of as Oussama has already mentioned. We did some of the preclinical animal work, looking at 2-minute versus 4-minute lesions. And coming out of that, we started down the road of Circadose and the question about whether or not the new generation cryoballoon, so it was about to hit the market, would be a game changer relative to the existing technologies. So Circadose was our, our high-level comparative study looking at contact force RF against the cryoballoon. We felt that the time to first recurrence endpoint wasn't reflective of the totality of what was happening when we did an ablation procedure. So that built in the link, and that sort of put us down the road for Circadose. Around the same time, we were having the same thoughts as Oussama was in terms of, was this a new tool set that was maybe a bit more generalizable in terms of the outcomes, a little bit more consistent with the outcomes. And on the heels of RAFT2, maybe we should look at first-line ablation again, but with a different technology. And so early AF came out of the publication of RAFT2. We enrolled Carlos Moreiro from Calgary now to be part of our steering committee, and we tried to make a first-line study that could address the question with this new tool set.
Did the two of you know about each other's trials as this was ongoing, given the similarities and the parallels in Medtronic's involvement?
So I knew about the involvement, or at least that Stop AF first was occurring. I don't remember where that was in terms of the designs. I mean, for us, it's been a 5-year journey to get to the point of publication. There's a European one as well, which is Cryo First, which we didn't mention, but they've also been presenting their data this year. And so, our study was launched in partnership with the Canadian government through something called the Cardiac Arrhythmia Network of Canada. And then we tried to leverage some of Industry Canada's involvement with Medtronic to partner with us from that end. But we were aware of other studies that were launching and that were going on at the same time.
So Jason, while we have you, in your words, how do you want the viewers to look at the results? Everyone's going to be reading the papers, discussing them in journal clubs. Let's hear it from the principal investigator and lead author. What are the results and what are the implications of early AF?
For early AF, I think the results, because we tried to be a little bit more than just arrhythmia outcomes, right? So we wanted the loop recorders because we really wanted to focus on more than just time to first recurrence. We wanted to be definitive in terms of how much arrhythmia was actually there in the background. So we didn't want to miss recurrences. But we also built in healthcare utilization. We built in quality of life. So on one hand, you don't have continuous rhythm monitoring of the efficacy of antiarrhythmic drugs. You have limited quality of life on antiarrhythmic drugs because the studies were just so old. So, from my perspective, early AF really gives us the whole picture of what a first-line treatment approach is. And it doesn't really matter what endpoint you want to use. For each of our arrhythmia endpoints, ablation was better than drugs. If you look at quality of life, the clinically important difference was more than twice exceeded between drugs and ablation. So ablation, again, improved quality of life more than drugs. And there was a tendency towards less hospitalizations. So I think, if you take all of those outcomes together, I think it gives you a comprehensive picture of the benefits of ablation as a first-line therapy.
So, and Oussama, what's the take-home message that you want Heart Rhythm members and viewers to have for Stop AF?
Just thank you both. I mean, we looked at the same outcomes, basically, arrhythmia recurrence, but we didn't put loop recorders. And we'll go back to the loop recorders and why I think that's very important. But also we looked at quality of life and healthcare utilization. Actually, the first time when I pitched the study, or when I envisioned the study, it was really mostly on healthcare utilization. And if you look at at least the Stop AFib, but also in early, healthcare utilization has to do with not only going back to the hospital, but also needing an ablation later on. So it's the same thing. You put them on AEDs, but they end up with an ablation anyway. Now, of course, some critics will say, well, you're allowing a lot of crossovers, but they reached an endpoint, and this is real life. This is what happens. I mean, if you have a patient who's already on an antiarrhythmic drug and they're not doing well or they're not tolerating it, the next thing you're going to offer them is an ablation. And this is exactly what was borne out in both studies. And the quality of life was better, and there was a tendency for less healthcare utilization in the ablation group.
And Oussama, what are the important differences between Stop AF as you see it and early AF? We can see there's a lot of similarities.
So the main differences is that we did not use loop recorders. We went by, remember, today, we still do an ablation for symptom relief. So we did we're looking at symptoms, and that's where the quality of life is. And also we're relying on the patients to tell us if they're doing well or not. But we also monitor them the usual way of monitoring with Holters and telephonic monitors and also ECGs. And the Stop AFib is really a simple study. Well, it was very simple. That's what I love about it. It's concise, it's simple, and the message is clear. And that's what I like about it. And it's very clear. So we did the ablation, as you saw, in about 100 patients, and another 100 patients got AEDs. The success rate was 75% in the ablation group and 45% at 1 year. And I want to here, bring the point is that it was just one ablation. We didn't allow more than one ablation. So it's just one ablation. And also, I want to emphasize that we included any arrhythmia as a failure. Because if you look at previous studies, they didn't consider atrial tachycardia or atrial flutter as a failure, the only AFib. But I made sure that it's any arrhythmia. And even with that very stringent parameters, ablation was successful in 75% of the patients and AEDs only 45%. And that's the nice thing about STOP AF is that it's such a simple study and self-explanatory. Really, anyone that reads it, even lay people will get the message.
Jason, do you think there are other important differences other than the ILRs between early AF and STOP AF?
I mean, the messaging of the studies, as Oussama has mentioned, is very similar. You know, we designed our study in isolation. So, you know, at the time when we launched it, we weren't aware of the other studies, but we had the benefit of people like Atul and Carlos Morillo involved. I mean, one of our big focuses is we did not want to have any crossovers. Like, we wanted the purest result that we could get because we thought that crossovers would just contaminate it. So we had an independent committee that had to review and approve it and offered guidance for medication titration. And we ended up having no patient crossing over from antiarrhythmic drugs to ablation before a primary endpoint. You know, we were aware of the limitations of rhythm monitoring when it's intermittent for a paroxysmal disease. The reality is you're going to miss recurrences. So the loop recorder was to give us our scientific endpoint of which one is truly better. But much like Oussama mentions, we don't do ablations for loop recorder detected atrial fibrillation. We do it for symptomatic improvement. So, you know, we had a 90% freedom from symptomatic AF at a year versus 73%. So our absolute difference was, you know, 16% between groups, giving a number needed to treat of 6. So, you know, really, it's just the question of, you know, why do we do this? And from a patient perspective, it's to prevent symptomatic recurrences and it's to improve quality of life. From a healthcare system standpoint, we want to see reduced hospitalization and healthcare utilization. You know, between the two studies, if you look at just healthcare utilization in aggregate, it's about a 30% reduction, which is significant. If you look at hospitalization between the two studies, the aggregate is actually a 60% reduction, which is again significant. So, you know, from a healthcare system standpoint, from a patient standpoint, from a cardiology, electrophysiology scientist standpoint, you get a very consistent message about what the benefit is.
One difference as I've studied these trials is that significant adverse events, obviously, this might have a lot of implications in terms of how much more ablation will be done in this community. And one important thing is to make sure that we have safety. And the significant adverse events, there were no difference between in both trials. You had 3 versus 4%, Jason and Oussama, you guys reported 14 versus 14. But importantly, majority of them, when you look at the fine print, were other, like 9%. Yeah. And I was going to ask you, I looked at all the details, and you had like back pain, you had a nephrolithiasis, a hepatic cyst.
So that happened. So this is one of the criticisms, but we have to remember that this was also FDA regulated. So one of the issues is that because STOP AF in the end is going to be used to hopefully expand indications, you had to include everything.
Right.
Yeah. So then you'll say,
and that's good for our viewers to know.
So why is back pain? Because that's why.
And obesity was one of the adverse events as well, which I found very interesting.
Well, complications from obesity, but anyway, so we had to include everything. Even when I was, looking through the list, we have all these, steering committee meetings, and each one of those we had to vet them and decide why it should be.
Absolutely.
And you've been involved in these kinds of studies, so that's why it's not out of the blue that we decided, oh yeah, let's do back pain,
Well, and that's why it's important for the viewers to understand that it's not really 14% significant adverse events.
So if we want to go through it,
it's very close to exactly what Jason reported when you look at it.
Exactly.
It's about 3%.
There was one effusion in the ablation group and a patient who had an MI later, so in the ablation group, and that's basically it. Two patients, and then in the AAD group, there was nothing severe, frankly. I mean, that we write it very clearly in the paper that all of these pro-arrhythmia events we did not see in this group of patients, and that's how it came out to be. We're not saying that AEDs are terrible. Now, in my own personal opinion, now outside the study, yes, AEDs can be dangerous and life-threatening. In the study, that was not the case.
And for fellows watching, and you want to look at proarrhythmia, Jason has a really nice in the supplement of 2 ILRs of wide complex tachycardia, as both of these trials had flecainide as predominant first choice as 1C agents. I want to try to finish up and be cognizant of the time here, but do you think, 2020 is a year we'll always remember with the pandemic, but then you have early, you have stop, and then you have east. And do you think that if we were to follow these patients long enough and have a large enough sample size, let's say, 5 times larger, we could show something with early intervention for reducing stroke and mortality, much like Cabana was set out to do?
Well, is a very large study, so I would probably have to, depend heavily on that in addition to our study, because in the end, our study was a 203 patient study, and
right.
Jason's was a 300 and some patient study. So those answers are difficult to get in just the hundreds, but we can rely on East. Now, the other issue I think that we always want to answer, and we try to answer, is ablation early? Does ablation early prevent progression of atrial fibrillation? And I know we have done studies ourselves and others, and have shown that yes, we're using surrogates, that it does. The question is very hard to answer, even with loop recorders, because Jason, even in your patients, and we want to go through them, but when they develop symptoms, you're going to ablate them. So that you're going to intervene at some point and interrupt that process, maybe. And that's why it will be difficult for us to say, unless we say no ablation for you forever because you're in the drug arm, and then we're going to see what happens. It's going to be hard for us to gain that piece of information. Yeah, and I'd be interested in Jason's insight on that.
I totally agree. I mean, our ongoing study has a 3-year follow-up phase. So I mean, the early AF primary result was set at a year. The intention of the 3-year follow-up is actually looking at progression and healthcare utilization over that prolonged time. I mean, all these people have loop recorders, so the intention was to just keep following them till the loop recorder battery dies and see how many go on to persistent AF. I mean, I think even though, there will be crossovers as time goes by and people fail drugs, but if you just look at the burden plot and just look at the 90th percentile dots, right? So even in the ablation arm within early AF, it's all concentrated down near the bottom. But then you look at the drug arm and you have up to 100% AF burden in the drug arm. I mean, this is a randomized study. That patient could have gone on to ablation the same as they got onto drugs. And you see a much larger spread of AF burden across that group. And so I think you already see the hints that that is going to be the case, that drugs just don't alter the progression. And based on the extent of observational data that we have to date, it suggests that that's what it is. But we'll continue following these patients as long as we can to try and address that.
So I'm going to push the both of you for predictions. We have the 3 trials, references 13 through 15, which were small studies. Now you got 2 blockbusters in New England Journal that really are clean studies, really clean in terms of the type of patients they're enrolling, how we're monitoring, one with loop, the other one with telephonic monitoring in 6 and 12-month Holters, and very clean messages of number needed to treat somewhere between 3 and 5 to reduce atrial arrhythmias. Is there any question in your mind that the next guideline iteration is not going to change to a class 1 with level of evidence A for first-line therapy? And what are the barriers?
So from a science standpoint, I don't think that there's any question regarding the benefit, right? Like if you take the 3 cryoballoon first-line studies and you take the 3 RF first-line studies, I mean, for the RF studies, you had 2 that were negative for symptomatic recurrence. You had 1 that was negative for any recurrence. Whereas the cryo studies are a very consistent relative risk reduction of about 50%, right? It's just the monitoring's different, so the numbers are different in terms of absolute event rates, but the relative benefit is very consistent. So from a science standpoint, I don't think there's any suggestion that it won't be elevated to a level of evidence A. I think the limitation's really just going to be the implementation, right? Like if you're suggesting every single patient with atrial fibrillation gets ablated, that's untenable from a healthcare system delivery standpoint, right? Drugs still had a benefit. They didn't completely fail. There were some patients who responded to drugs. So it's not that it's not a viable treatment option, but if you hold the evidence for first-line ablation to the same standard that you had the evidence for drug failures. You now have multiple studies giving the same results, showing the superiority of ablation over drugs.
Oussama, any question in your mind that basically drug naive, it doesn't require you to fail medications anymore?
There is no, again, like Jason said, I don't think so. I think that we are at the level of evidence A, where we can offer ablation as initial therapy for the patients. Now, the question is the patient selection. It's not that about, okay, first of all, the main question that we have to answer is, do we need to address that atrial fibrillation in a specific patient? And if the answer is yes, the patient has symptomatic atrial fibrillation, and we have established that it's not a one-off episode because of acute illness or hyperthyroidism, because we have to be also cognizant and conscientious in what we do, then I think it is very reasonable to offer the patient ablation as an initial therapy. Now, practically speaking, we also have to have, some parameters with what we will work with. So is it one after the first episode ever of AFib or after your second episode of AFib? And we know some patients will have an episode of AFib today and won't have another one for 10 years. So if we ablate them right after that first episode and we do an ablation, then it'll be a 10-year success rate.
Sure.
100% success rate. So there is going to be some qualifications and some parameters around which we can offer ablation as initial therapy.
And just to give a very balanced view of this for our viewers, when you look at the burden recorded by the ILRs in early AF, the median burden was 0% in the ablation group, but the median burden was 0.13% in the medication arm. So again, it's not to say medications don't work. It's just the time to the first event is certainly different. And if patients are looking for the quick fix, then it seems like that's the correct move based on these two studies, but it's not the only way to do this. So I really appreciate you joining us on Heart Rhythm TV, both of you taking time out of busy schedules. A huge congratulations to both of you for taking on these clinical trials and getting them into the New England Journal of Medicine. Thank you for representing the electrophysiological community and HRS in a primetime internal medicine journal. This is fantastic, and congratulations.
Thank you, Rod, so much. This has been great. And thank you, Jason, for a fantastic plan also. Thank you.
You too.